You know, the first time we reported on PCSK9s in Cardiosource World News was based on a bunch of different studies that were presented at the AHA meeting in 2012. Now we are at the AHA meeting in 2015. We're talking about one of the recently approved PCSK9 inhibitors. Alirocumab was approved by the FDA July 24th, 2015 as a second-line treatment for high cholesterol for adults whose cholesterol is not controlled by diet and statin treatment. And the editor-in-chief of Cardiosource World News at that time, back when that first article appeared, is with me right now. So perfect combination. Dr. Chris Cannon, who is the senior physician, Brigham and Women's Hospital, and professor of medicine at Harvard, correct? I got that right? Yeah, if I didn't, I'm in big trouble, right? And if you would be so kind, alirocumab has been approved. This has been an amazing ride with these drugs. There's some new stuff, though, here that I think is really interesting. So let's talk about it.
Well, it is amazingly quick to have a concept turned into a drug that we've actually been able to give to patients. So I have one person that is on it and another one that I'm about to. And so now we're getting into more of the practical issues of, do we have data in this subgroup or that, and what do things look like? And several abstracts here. And then, more, that's on the practical side. And then on the concept of the issue of Newonset diabetes, which thankfully the answer is no, but that's a really hot topic in lipid therapies. So starting with subgroups, I think diabetes patients who we know are at high risk, and so we did one analysis looking at what are the effects on lipids in the diabetic patients. So in fact, in the Combo 2 study, which is mostly patients with known disease, with or without diabetes, thankfully about a 50% plus reduction in LDL, and had a direct comparison to ezetimibe, known to be good for protecting against heart attacks, but that's only about a 20% reduction in LDL. And so if you need to more than 20% reduction, the PCSK9 really looked good and performed equally well in diabetics and not, and no differential in side effects, thankfully. Another similar subgroup where there's more concern on the side effects is patients with CKD. Yes. So another high-risk group, and same story, that the same LDL reduction of just over 50% seen with alirocumab versus there sometimes placebo, other times ezetimibe. And so consistent results.
And safety was not an issue.
And thankfully safety is not an issue. I think injection site reactions in less than 5% is sort of the thing that you'd expect and was seen. The third thing is choosing what dose. And yes. So that's an interesting thing. And so with alirocumab, there are 2 doses available and approved. And the label notes that one can start with the usual starting dose, is the term that they use, is 75 milligrams given every 2 weeks. And quite amazingly, across the whole program, that has worked in getting people to their goal in 75% of the time. And so then if you do need to up-titrate, we saw in this abstract John Castelline presented about an additional 14% lowering in LDL is what was observed. And then a question I asked as we were developing this of, well, okay, let's look at the baseline LDL when you're sort of pulling the trigger to say, yes, I need to add on top of maximal statin therapy. And amazingly enough, even for people from 160 to 190, half of them got to goal on the 75 milligrams. And so, and then above 190, I think that's clearly a group you could do, but even some of those, about a little over 40% of them got to goal on the lower dose. And so it shows how powerful this class of drugs is. And so this notion of a starting dose, as FDA likes, it looks like a very reasonable strategy, but the 150 is available if needed.
Now, one of the things that I wanted to ask you is at this meeting there is a presentation that's talking about after the ACC-AHA guidelines were published, changing the cholesterol guidelines and recommendations, they did a study to see how many more patients, if any, were assigned to high-intensity statins. And even though the guidelines suggest it, the uptick was very small, and there's still a lot of unprotected patients out there. Will a drug like this be beneficial in order to get more patients on a medication, maybe avoid the high-intensity statin and either an alternative or simply a combo?
Well, two aspects of that I think as new therapies become available, we look back and are pushed because of the cost of this class of drugs to make sure we're maximizing the less expensive therapy. So that's good. And it gets away from the inertia, which unfortunately was a fallout from the 2013 guideline of, oh, just use statins and you're good. Thankfully, we have more data since then that will prompt an update. But practically, we do have to relook at each patient and say, are we giving them what we should? And it has been a surprise how few people are on intensive statin therapy despite the multiple trials showing the benefit.
I know. There's a frustration there.
Now, the other aspect of that is actually the subject of the final new abstract that Helen Calhoun is presenting on the issue of new-onset diabetes. So this is seen with Jupiter of rosuvastatin versus placebo. It turns out in the meta-analysis it's there in all the trials. It's a modest increase, counterbalanced by far in terms of the benefit in preventing clinical events, but it's there. And then we saw with high dose versus regular dose, there is a higher risk of new onset diabetes. So then people said, well, wait a minute, what about with PCSK9? And so that's the subject of this analysis. And thankfully, a lot of data, I think it's 5,000 or 6,000 patients with serial hemoglobin A1C, serial fasting glucose. There's no increase in the risk of new onset diabetes as an adverse event reported by docs or on hemoglobin A1C or fasting glucose. So very reassuring that this new potent therapy doesn't have that side effect that does appear to be there with statins. Now we'll figure out how to incorporate that. I think we're usually going for the LDL, obviously statin first, that's part of the appropriate regimen. But I think reassuring safety side of the equation on this potent new class of drugs.
Well, we have been covering this, obviously, for CardioSource World News now for several years, and we're going to continue because this is a great topic, and I'm so glad you had a few minutes to chat. After working together for so long, this is the first time we've actually been on camera together. Isn't that shocking? We have in CardioSource World News a variety of stories from the AHA meeting and the highlights, so please check out both CardioSource World News and CardioSource World News Interventions, where I am the executive producer, Rick McGuire.